Hello, everyone. My name is Jason Kitterchuk, and I'm an assistant professor at the Max Reddy College of Medicine and Department of Medical Microbiology and Infectious Diseases here at the University of Manitoba. I'd like to welcome everyone to this webinar on Monkeypox Diagnostics, which is a part of a webinar series hosted by NCCID in partnership with the Public Health Agency of Canada and the Association of Medical Microbiology and Infectious Disease Canada. I'd first like to acknowledge that we are located at the University of Manitoba on Treaty 1 territory, in the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. Let us acknowledge the harms of the past and dedicate ourselves to actively work towards reconciliation through collaboration with Indigenous communities. So first, just a few housekeeping items before we begin. Firstly, the chat tab will be used for communication with attendees, so please check there for updates. If you have technical problems with Zoom, please send us a message using the email provided in the chat box. This webinar is taking place in both English and French with simultaneous French interpretation, which can be accessed in the interpretation tab at the bottom. There's an option to mute the original audio to listen to French only. The question period will be at the end of the presentations and will be taking place in the Q&A tab. The recordings of this webinar will be available at nccid.ca under the webcasts tab shortly after the webinar. And now I'd like to introduce our speakers for today. Firstly, we have Dr. Adrienne Chan, who's an infectious disease physician and Associate Medical Director of Infection Prevention and Control at Sunnybrook Health Sciences Center. She's also an Associate Professor of Medicine at the University of Toronto. Our second speaker is Dr. Jonathan Gabay, who is a medical microbiologist with Public Health Ontario and an associate professor in the Department of Laboratory Medicine and Pathobiology, as well as in pediatrics at the University of Toronto. Thank you both for being here today, and I'll now turn the mic over to Dr. Adrienne Chan.
Thank you, Jason. I'm just quickly setting up my tech. Just give me 1 second. I'll try this again. Sorry. Great. I hope you can all see this. Someone please flag to me if there's any issues. It's my pleasure to have the opportunity to speak along with Dr. Gabay today about monkeypox with a focus specifically on diagnosis, the clinical aspects, as well as the laboratory aspects for our primary care colleagues. Just in terms of the land acknowledgement for both myself and Jonathan, I thought I would show a mural near where I live that was done by a collective of Indigenous artists called Corano Past, Corano Future, which is a reminder to me, especially in the context of our work, about how we are all globally interconnected through time as well as geographically. And this mural is meant to represent how Corano was a meeting place for all people, first for Indigenous nations for travel, trade, hunting, and fishing, and now in the present day for people who come here from across the globe to gather on the traditional territories of the Mississaugas of the Credit, the Anishinaabe, Chippewa, Haudenosaunee, and Wendat peoples. I didn't want to replicate the talks that were already conducted by some of my colleagues and that are available in the rich resources on the NCCID website, including a nice webinar on infection prevention and control, as well as on a general overview of the public health response, case management, clinical presentation, community engagement, and a nice summary also of tecovirimat treatment. Instead, I wanted to update a bit on our understanding of the current epidemiology since the last NCCID webinar, and use this as an opportunity to update lessons learned from clinical features of cases that we're seeing in Toronto, using a small collection of suspect and confirmed cases that we've seen with some features slightly adjusted in order to protect personal health identity. Finally, I wanted to provide a general approach to the diagnosis of monkeypox in the primary care setting before turning over to Dr. Gabay, who will go through the laboratory aspects. I think we're all aware by now that that monkeypox is a concern. It is a member of the Poxviridae family, orthopox virus genus, and prior to this year had been endemic to Africa with only sporadic cases and outbreaks happening outside of non-endemic settings. Within Africa, particularly affected has been Central Africa. And we know that there are two different clades, the Central African clade as well as the West African clade, which also we know have different clinical severities and outcomes with a higher mortality rate in the Central African clade of virus. Previously in Africa, primarily transmission was primary infection from zoonosis and then household and community spread. But since April of 2002, we've had really an explosion of cases outside of endemic settings. And when I actually checked in the last WHO meeting I was at around a clinical trials protocol, they at that time, I think it was just 10 days ago, it said that there were about 7,000 cases that they were looking into worldwide. We're now at over 14,000 cases with over 8,000 cases in the EU, over 2,000 cases each in UK and the US. About 1,400 to 1,500 cases documented in several countries in Africa that are tracking this. And I think the WHO is currently meeting about whether or not we need to move to declare this a public health emergency of international concern. Within Canada, the most updated data from public health agencies suggests that there's over 600 cases, predominantly in Ontario and in Quebec, which is where case reporting started in May of 2022. There are also a few dozen cases in BC, Alberta, and Saskatchewan. At the last WHO epidemiology update, which is readily available at this web link here for those who are interested, including some very interesting presentations by colleagues from the DRC, they reported that based on publicly available sources, of the cases that they had been tracking using their WHO case report form, 99.4% of cases identified as male, median age of 37. And in cases where questions were asked about sexual orientation, 98.1% of cases identified as a man who had sex with men and 0.8% as a bisexual male. There was some data asked around HIV status, and in the case report forms where HIV status was documented, about 41% were HIV positive. And while there's no data on the WHO data around the status of immunosuppression or whether or not patients on ART, I'm sure many of you have seen the recently published article in the New England Journal of Medicine yesterday, released by the ShareNet group, which looked at about 528 confirmed cases, which is the largest case series to date from 43 centers in 16 countries. And within that group, they specifically had an interest in looking at the proportion that were HIV positive. It was similar to what the WHO data reflected. And 97% of those individuals had a viral load suppressed less than 200 with a median CD4 count of 600. So the HIV patients that we're seeing are not significantly immunocompromised. Global data suggests that about 9% of patients in this current outbreak are hospitalized primarily for pain management, but also for isolation in cases where they do isolate patients with monkeypox. But what we're seeing is that the severity of the disease seems to be low, with a very low number of people requiring ICU admission, although serious complications have been reported, as evidenced by the recent New England Journal article, which reported, for example, 2 or 3 cases of myocarditis. As far as I understand, there are only 5 reported cases of deaths, and all of those are occurring in African countries with not a significant amount of detail as to cause of death. When the WHO looked at exposures, predominantly the epidemiological risks seem to be social gatherings with sexual contact. There are cases that occur in large events with sexual contact, also in social settings with no sexual contact, and also in household contact. The data from the WHO and also from the New England Journal paper, understanding that there will be selection bias in reporting and ascertainment bias, suggests that 95% of cases at this time are associated with close sexual contact. Although there's not been any formal documentation of sexual transmission, the New England paper also was able to document detectable PCR, but no cultural virus in seminal fluid of 29 of 32 cases in which it was detected. The incubation period for this virus doesn't seem to have changed from what had been previously reported, with a mean of somewhere between 7 and 9 days, but there does seem to be a relatively wide range, with as low as 3 days reported in the ShareNet paper and up to 20 days. And I think this is quite reasonably justifies the 21-day guidance that we're using for contact tracing. The data on serial intervals looking at case and contact pairs, looking at the time from symptom onset from cases to the time of symptom onset in their contacts, suggests a mean serial interval of about 9.8 days, which also suggests that transmission occurs fairly early on after symptoms. So as a primary care physician, I think one of the important things to note is that a lot of the information that's out there about historical presentation likely is reflective of a lot of our information about this disease coming from low resource settings where patients who might access care and might have access to testing might be more likely to have more severe presentation of disease. And so typically the prior descriptions really focused on this idea of having a significant febrile systemic prodrome prior to the presentation of rash associated with lymphadenopathy and then progression of rash over 2 to 4 weeks. Certainly, the observations in the patients that we've all been seeing are showing a few new things that I think are important to highlight for primary care clinicians. Firstly, that the rash may occur often before the onset of a febrile illness and that a febrile prodrome may not occur. That there may be subsequent secondary waves of lesions, and the classical teaching that all of the lesions appear all at once, like smallpox. I think definitely we're not seeing that. We're seeing a lot of developmental polymorphism of secondary lesions. I think we're also seeing lesions where they're at the sites of inoculation. So a lot of descriptions of oral lesions, oral mucosal lesions, as well as a predominance of anogenital lesions as well. And what's interesting is they may often occur just as the primary lesions as solitary. And so there is the risk that it could be confused with other STIs, in particular syphilis. Finally, we are also seeing patients present with the significantly debilitating proctitis, where the pain will be quite debilitating to the point where some patients may need to be hospitalized. There may be issues around GI bleeding. And interestingly, this may or may not be in the context of also a concomitant perianal disease. This is a nice slide put together by Sharon Sikdea, one of our infectious diseases fellows, who's been charged with kind of keeping an atlas library of images, which we're hoping to create a publicly available site for in order to help frontline clinicians identify cases, which shows the progression of disease. Typically, it starts with a macular papule. A lot of people think that it's just acne or a bump, early folliculitis or a rash. It then will subsequently, in cases, develop into a pustule, and these are very characteristic with umbilication here, similar to what we see in molluscum. But often the pustule itself, to be honest, it looks more pustular than vesicular, and also the consistency of it can be almost a bit indurated when you're pressing, less boggy than I think that you would expect, especially as it goes into the period of disease where I think that symptoms are most significant. Over time, the umbilication will regress and the patient may develop an ulcer if the roof of the lesion is unroofed, then develop crust, and then have desquamation with re-epithelialization and scar. And it's at this stage, when the patients reach this stage, that we typically clear them from isolation. So I'm now going to go through a series of cases, and then just for you to think in your mind what you think is going on. Some of them were suspect monkeypox cases that ended up not being monkeypox, but I think this is just a good mental exercise for us all to go through. And the one thing I've learned from this, constantly learning, is how important it is to have clinical humility and also not to have cognitive anchoring, especially when a new disease is emerging. So this is a first case, is a patient that we had been referred, who was referred with a lip ulcer, had a prior history of cold sores, and was also HIV positive, but well controlled on Biktarvy with an undetectable viral load. He had had 4 regular partners in the past few months and was last sexually active 2 days and 1 week prior to clinical presentation. And at that time had mutual oral intercourse as well as top and bottoming. He presented with 2 weeks prior of some systemic symptoms with a stuffy nose, head congestion, and an itchy throat, but felt this was consistent with seasonal allergies that he had every year. And then came to the emerge because he had a 4-day history of a vesicular lesion on his upper lip that was initially painful and crusted and is now healing with no symptoms. Of note, he had no fever, lymphadenopathy, or systemic symptoms. And here you can see a crusted over a lesion with some in the lip area. So in your mind, think of where you would land in terms of low, medium, or high. So this gentleman was discharged from the emergency with ID follow-up. And then we saw him, and at that time had a low suspicion for monkeypox given his prior history of HSV1. We ended up swabbing him, and he was test negative for monkeypox, but positive for HSV1. So he was given a diagnosis of HSV. This second case is a 40-year-old gentleman who has no past medical history and is well, but taking pre-exposure prophylaxis with tenofovir and emtricitabine. Was recently treated for rectal chlamydia with doxycycline, and had a new partner at 21 days, same partner, and 13 days again prior to presentation in the ED with mutual oral intercourse, a rimming, and also he was topping. This gentleman described developing bumps on the genital area and lips about 10 days prior to the presentation, and then developed some systemic symptoms with adenopathy 4 days prior to presentation, and ended up coming to the emergency with a new crop of lesions as well as significant retrosternal chest pain that was worth lying down. This is an example of the ulcerative lesion with crusting. You can see here, it's a little bit deeper than the other lesion. And you can also convince yourself that there may be a pustular lesion developing here in the fold. This gentleman also had 2 ulcerative lesions in the genital area. This was on the just at the end of the shaft of the penis, and this was in the inguinal area where you can see a pustular lesion. So again, if I could have you think about what your clinical suspicion for monkeypox would be. So this gentleman was admitted to the hospital due to myocarditis. And I believe the ShareNet case reported this gentleman as one of the 2 cases they reported about. And we've now heard of 3 cases of myocarditis associated with monkeypox, all of which I understand have recovered well. All of the lesions that this gentleman had swabbed were positive. He also had a positive rectal swab for monkeypox. And concomitant gonorrhea and chlamydia diagnosed in the throat and rectum, and was eventually discharged with resolution of symptoms. I think some case notes to comment on. At the time, tecovirimat, TPOXX, was not available in our province, but this is someone who would be a candidate for treatment now as a hospitalized patient with a severe manifestation. Other complications of note, there have been case reports of AKI. We've also had some cases of keratitis that required treatments that had conjunctival swab positivity. Significant pharyngitis has been reported as well, with patients having difficulty swallowing, significant pain where they're unable to ingest things. One patient who was admitted with epiglottitis, and we now also have a patient who had presented with retrosternal chest pain, swallowing hot liquids that has an esophageal lesion as well. Significant proctitis I've already discussed, and then bacterial superinfection. The other clinical note I wanted to comment on is that STI co-infection is very common. And at the beginning, we were seeing a lot of patients that were being swabbed for monkeypox, but weren't having STI testing. And so I think it's really important to do in the initial visit, understanding that there are some laboratory implications where the samples get delayed while they wait for monkeypox clearance. And so if that doesn't get done at the first visit, like every effort should be made to have it done soon after the initial visit, or to consider empiric treatment if testing cannot occur in a timely fashion. The ShareNet series reported that almost 30% of patients also had a co-infection with a variety of STIs, including gonorrhea, chlamydia, chancroid, HSV. And they also commented on 2 newly diagnoses of cases of HIV in the ShareNet series. And we've also had 2 newly diagnoses of cases of HIV in our patients in Toronto. And so I think it's really important to make sure we do testing. You can send off the testing. Most labs will just require that you label that they're suspect monkeypox, and most labs can also do HSV PCR off the monkeypox samples after extraction, so I think that's helpful as well. Just a reminder, primary lesions do occur at the sites of inoculation. This is an example of the progression of some penile lesions, and this is an example of perianal disease as well. This third case is a 30-year-old gentleman who presented with severe proctitis and ulcerating perianal lesions, a 2-week history of a viral prodrome with myalgias, chills, and hot flashes, and a runny nose that he'd attributed to a cold. 10 days prior to presentation, he had unprotected receptive anal intercourse with his only partner with whom he is monogamous, and also mutual oral intercourse with that rimming. Now, they had intercourse at a bathhouse in a hot tub, but did not engage in activity with any other individuals at the time. And 4 days after his last sexual exposure, he began to develop a rash on his perirectal area. His systemic symptoms prior to that he had attributed to a cold had started to abate, but worsened again after the onset of symptoms, and came to the emergency because of significant progression of the pain and ulceration, and was unable to defecate. Here is a photo of his lesions, which you can see show kind of a symmetrical ulceration, small punched out ulcerations on both sides. And then you can also see these kind of separate vesicles here, which may or may not have some umbilication that are separated from it. So in your minds again, if I'd like you to go through the exercise of whether or not you feel this is low, medium, or high probability for monkeypox. Now, he knew that his partner that he'd been with was asymptomatic. And so in our differential was both monkeypox and herpes. Empirically, he was started in the emergency on Valtrex, but swabbing was done of the vesicular lesions and also a rectal swab, which ended up being monkeypox and ended up being positive for herpes. So again, a reminder that there are other things in the differential diagnosis, and that's what has made the diagnosis a bit challenging at the beginning, which is why I think that if you're not sure, it's probably better to test. One of the nice things about the New England article is that in the appendix, there's some really rich collection of images that our colleagues have shared. So for those of you who are less familiar with the clinical presentation, you can take a look at some of the images there and give you a sense of the spectrum of presentation. So just to compare the perianal herpes that I'd shown with perianal monkeypox lesions, you should be aware that 73% of the patients in the ShareNet case series did have anal genital disease. I think this is one of this is a submitted case from Canada and shows evidence of kind of perianal monkeypox. This is more of what a solitary lesion might look like with ulceration, and this one is still vesicular. But it can also look quite atypical. So these other 3 lesions look slightly different than I think the 2 previous, which were a bit more classic, including this lesion right here, which is solitary. And so about 10% of the patients in the ShareNet case series only had a single genital lesion. So you could see that this might be easily confused with things like syphilis. And so if you're thinking syphilis, this should be in the differential, and you can also consider swabbing at that time. This is a case that we saw early on, a 34-year-old female who lives with her husband and children, has a history of eczema, and traveled to the Turks and Caicos to a sandals resort with her extended family. Her kids at that time attended the day program, and she noted while she was still in the Turks and Caicos some blistering on her palms, but that happened a lot because of her eczema. Her son then developed fever. And on return to Canada, the nephew that she was with developed conjunctivitis, fever, and progressive rash on the hands and buttocks. The son also developed 4 papules on the forearms, and then she awoke upon return with chills and pruritic macules on her and papules on her hands that spread to her heels, inner thighs, and lips. Was seen in a walk-in clinic and prescribed topical steroids, and then presented to the emergency essentially with debilitation, being unable to walk. So these are her lesions, which are primarily maculopapular, or although you can see that there's some crusting, and perhaps here on the foot could be convinced that there is a vesicular lesion as well. So again, going through the mental exercise, this lady was admitted to the medical short stay unit because of difficulty ambulating, and they were very, very concerned that the patient had monkeypox. We actually didn't end up testing her because I think we felt quite comfortable making a clinical diagnosis, as did the family doctor, the dermatologist, and our colleague at Sick Children's Hospital. So hand, foot, mouth disease comes up a lot. I think, if it's in a child, it's much more likely to be hand, foot, mouth disease. Some things to think about for you guys are that often there's no adenopathy, and there's quite a short incubation period. And the other thing is, we all know hand, foot, mouth disease come in clusters, right? So everyone in the family getting it, everyone in daycare, everyone in camp, those are the sorts of things to think about. It also will often appear in the mouth before spreading to the rest of the body. So those are some clues to think about for hand, foot, and mouth. You can see the monkeypox hand lesions. These are much more typical ones. These kind of like bigger lesions that are a bit more indurated in the area of vesicle. But here's one of a patient who ended up having a monkeypox, where I could see that this lesion is, it's pretty non-specific, right? So it could be easily confused with anaerovirus infection. So just to keep in mind, this is much more typical for hand or foot lesions. Here's another good example. Again, here are lesions that are monkeypox lesions. Certainly disseminated gonococcal infection can sometimes look like this, although usually typically a bit more pustular. These are some resolving sole lesions of a patient with monkeypox. Definitely on the differential for this would be syphilis as well. The fifth case I have is a 30-year-old gentleman who is HIV positive on Juluca with well-controlled disease, who had been well 3 days prior to admission when he woke up from a long midday nap with systemic symptoms. And one day prior to contact, he noticed 1 or 2 pimples on his hands, and over the next day developed lesions on his face, hands, arm, back, torso, and legs. He did also have a lesion on his foreskin and 1 on the glands, and some pain internally in the anal area, but no visible lesions, and had systemic symptoms when I saw him. The lesions felt itchy, but he had no pain, and it reminded him of his recollection of chickenpox that he had as a child. So this is how his lesions look when I saw him. So you can see maculopapular lesions with just the beginning of vesicles forming. And then here you can see some subtle vesicles that you could almost convince that it looks like a dewdrop on a rose petal kind of a look to it. So obviously chickenpox would be in the differential, but this is someone who had it already. And so we did swab him, and he ended up being monkeypox positive on all 3 lesions that we swabbed on his blood and also in his rectum. He's doing well and convalescing with no indications for TPOX. So one clinical note to highlight here is obviously we're concerned with the number of patients with HIV who are getting it, but certainly, although we have very little information in HIV patients who are not immunocompromised, who are immunocompromised, we have very little information on HIV patients who are immunocompromised, at least in HIV patients who aren't immunocompromised and who have well-controlled disease with a high median CD4, the outcomes are similar to patients that don't have HIV. There are case series in Africa, though, that suggest that patients who have HIV and do not have well-controlled disease do have worse outcomes. So how to differentiate it from varicella zoster? I think having had a history of zoster would be helpful, or a history of immunization. Typically, zoster will start on the chest, back, and face and spread to the rest of the body. And the temporal progression of zoster is like much faster. So we see the lesions, they come and go over days. The temporal progressions of the cutaneous lesions, at least of disseminated monkeypox, seems to be a little bit while longer. Okay, so I think in the interest of time, I might skip past this one because this is a case that was presented. This is a case that was published in the CMAJ, but just again, a nice example of the developmental polymorphism of lesions. So this is very classic looking umbilicated lesions of a photo in a patient. At the same time, this gentleman also had these crusted looking lesions. So clearly on the body, different lesions at different times. The other thing I wanted to highlight about that particular case is that particular gentleman had extremely debilitating proctitis for which he had to go to the emergency 3 or 4 times. And I think now, because we're seeing that about 10% of cases are developing severe anal rectal pain, affecting function, many of these patients, depending on your jurisdiction, can be considered for tecovirimat, and we're seeing some good clinical response. And there are currently plans by the WHO, as well as the Canadian HIV Trials Network, and other groups, including an Oxford group, to be involved in a collective global outpatient trial looking at outpatient therapeutics to help with resolution of disease. I wanted to end with this case just to think about these ideas of cognitive anchoring. So we are seeing women come in, and it's important to remember that, you know, although there is clearly an epidemiological association with disproportionate risk right now in MSM, monkeypox is a disease that's really just associated with close contact. And so you just really have to think about it still in women and children where there is a potential epidemiologic link to a positive case, or if they're presenting with an atypical rash. So this is a woman who's a member of the LGBT community who presented with malaise, subjective chills for 3 days, and 2 days of diarrhea and emesis, who presented with the onset of painful papules with pustules in her mid to lower back. She had a past medical history of endometriosis, and her last sexual contact was over 21 days ago, but she was quite worried because she had attended Pride in Toronto, which is really pretty much packed body to body in the parade area and also in some of the social events. She did not kiss or hug anybody, but was dancing and in close contact with a number of people. And she did go to a party about 5 to 7 days prior to presentation at a friend's house where she did share a hot tub with a number of people. So these are the lesions that she presented with. They look very much like folliculitis. And so think about what your clinical suspicion would be. We ended up swabbing her, and her monkeypox swabs were negative, but I wondered if she might have hot tub folliculitis. And so we swabbed her for that, and she ended up growing Pseudomonas aeruginosa, and we treated her for that. So that same week, one of my colleagues saw a similar case, again, a woman who is a member of the LGBT community, who was also very actively involved in events at Pride, without any sexual contact, but with a lot of hugging, who presented with a solitary axillary lesion and then some dissemination in the body that was swabbed and ended up being positive. And so that I think is our first female case that we've had. So I think the important thing to remember, again, is this idea of clinical humility and not having cognitive anchoring around epidemiology. But as you build your experience around cases, I think you'll get a better sense of how high or low a suspicion to have. And as diagnostics become available, obviously, for you to swab and send in order to get the results that you need in order to make decisions. This is a general clinical approach that was put together by Dr. Sigdeo that I thought was really nice. When you see the patient in your clinic or in an STI clinic or in the emergency, first thing to do is to apply appropriate precautions, put them in their own room. It doesn't necessarily need to be a negative pressure room as long as it's a room with a closable door. You want to notify your local public health unit, or if you're in a hospital institution, like through an ED or institutional IPAC, as well as notifying either your local lab or the public health lab for your province. We talked about some issues to look at for history, what to look at in physical exam. And for diagnostics, the one thing I can stress is go after the lesions. The yield is so high, and we've been able to get it on dry swabs as well. So really go after the lesions. Rectal lesions are particularly helpful, or doing a rectal swab in patients who have rectal symptoms. We are finding NP and pharyngeal to be slightly less useful unless somebody has pharyngeal symptoms. We were doing serum PCR, and it has been positive in patients who are in the middle of their clinical prodrome, but it is something that you can decide not to do if it's logistically challenging to do in the primary care setting. For each of the case, you need to counsel them about isolation, see whether or not they meet criteria for treatment, and then obviously public health unit will get involved in contact tracing and establishing whether or not people require a post-exposure prophylaxis. Here's a list of things to think about in terms of the infectious diseases differential diagnosis, and again, stressing the importance of looking for co-infections. So before I hand over to Dr. Gabe, just wanted to give you a sense of how you're going to be doing the swabs. I have my viral transport media here with my swab. At our institution, we actually had kits made up to help with our emergency department. This is really helpful, I think, for flow in the emerge as well. But essentially what you want to do is to unroof a lesion and swab it. If it's difficult to unroof a lesion because it's early on, sometimes I'll just do a dry swab or kind of mash it in there. I do try hard to not swab lesions that I know will be painful afterwards. So I often try to avoid swabbing penile lesions if there are other lesions to go after. I also try to avoid swabbing lesions on the hands and feet, which can also be really painful afterwards. So if there are nice looking lesions on the torso or back, also where there won't be visibility and potential scarring, those are the lesions I've been going for when I've been choosing to swab lesions. So I will hand over right now to Dr. Gabe.
Great, thank you so much, Dr. Chan, for the excellent presentation on clinical diagnosis. I'll now ask Dr. Gabe to please begin your presentation.
Hi, I'm just going to get my camera on, and we can get started. Hi, everyone. Thank you so much for asking me to present. And hopefully it'll be a nice compliment to Adrian's fantastic presentation. Just let me know if my slides are not showing. I'm going to apologize to anybody that doesn't live in Ontario, because what I do know very well is monkeypox testing in Ontario, and haven't really had a chance to get my head out of the Ontario sand to tell you exactly what's happening in other provinces, but have some idea through some of our national networks. So just conflicts of interest. I am a consultant scientific editor for Gideon, but doesn't really have much impact on this talk. So in terms of the lab testing, I'm going to try and cover some key areas. I think Adrian's actually done more on specimen collection than I will, so that's helpful. I'm going to talk a bit about specimen packaging and transportation. I'm going to look at what we've been doing for lab testing in Ontario. It's not going to be the same across the country, but I think it's going to be similar themes at the different provincial public health labs. I'm going to show you some nice data from our laboratory from our early period of testing, and I think it helps provide some strong reinforcement about skin being the preferred specimen, and that probably if you have at least 2 to 3 good skin specimens, there's no point submitting other specimen types. And I'm just going to discuss a bit more on the high enterovirus positivity amongst the kids that are being tested at this time. So just some quick overview of the family of Poxviridae. So the key genera are the orthopox viruses. So that includes smallpox, vaccinia, the virus in the vaccine, cowpox, monkeypox, and camelpox. The important thing to know is that monkeypox is the only one that we see in clinical infections in Canada at this time. So if you're doing an orthopox virus test and it's positive, you can presume that the patient does have monkeypox, though we do usually go on and do the specific monkeypox testing. The other important genera, molluscpox, so that has molluscum contagiosum virus, one of the differential diagnoses that you've already heard about, and then parapox virus that includes ORF and pseudo cowpox viruses. Just a nice schematic of the virus, which isn't, it's an enveloped brick-shaped virus, about 250 nanometers in size, and it has a double-stranded genome, which is quite large, up to 250 kilobytes. From an infection control perspective, just remembering that it's a lipid envelope virus means that it is easily inactivated with any hospital-grade disinfectants, and the same with any soiled linens through routine washing with household cleaning products, washing products. This will be enough to decontaminate any sort of linens that may have been exposed. And actually, this is the kit that I think Adrian was holding up. Her colleague Rob Kozak did supply these photographs for us to put on a slide as an example of a collection kit that's pre-prepared, which I think is very helpful for the frontline clinicians, and also has some nice clean directions. I think these slides will be made available, but Rob has said anybody's welcome to take this and adapt it for their circumstances, or you can email me later if you want to get the actual Word documents. But it has a really nice step-by-step instructions of like how to collect, a lesion swab. I won't go through it step by step, but I think having that is very helpful, especially in places that aren't seeing many patients that they may need to test. One thing that's not on the slides that I'll mention is I know there's a lot of talk about putting lesions into dry containers to sort of reduce the dilution in the transport media. I think we're finding it's probably not critical to do that. It's fine to do it dry if required, but we are having to dilute that anyway to be able to do the testing. At our lab, we add 500 microliters of UTM just to allow to have something to extract. But if it's in 1 to 2 mils of UTM, that's fine. It really doesn't have a big impact on the sensitivity of the test overall, but obviously need to check with what your lab that's providing testing wants you to do. Interestingly, if people look at what's on the CDC site, they do a couple of things that are a bit different to what is in our current recommendations. And maybe when we can get some more background from the CDC, we might understand why they've said this, but they've specifically said that it's not necessary to de-roof a lesion before swabbing. I mean, that does sort of go against what we usually do for vesicular lesions. So that's something to look out for, to see if we can get some more details around why they make that statement, and perhaps that will change in Canada as well in the future. They ask for 2 swabs from each lesion. So just down the bottom, my sort of commentary on that is I probably still would de-roof a lesion when collecting. If there's multiple lesions, I would do 1 swab per lesion rather than 2 from individual ones. But if there was only 1, then it does probably make sense to take 2 swabs from that lesion. It's good to put each swab that you take in its own specimen collection container. It just helps to add more specificity to your results, so that if you're getting positive results from multiple collections that came in separately, it's better than like saying swabbing multiple lesions and giving 1 swab, or pooling swabs into the same container. Again, that's our approach in Ontario. You might find that your local lab has a different approach, but that's what we find to be very helpful in sorting out cases where the epi doesn't necessarily match and we're seeing a positive result. So I'm not sure what happened. My slides dropped down. Let me just look for them. That's strange. Has that disappeared off the screen there? I'm just gonna have to open it up again. I have no idea what happened then. Just be a sec. Can someone let me know if you're seeing the slides? Or do I need to reshare?
We can see them.
Okay.
Thank you.
I'm not sure what happened then. Back to where we were. Yeah, so as Adrian mentioned, that patients can be seen in any clinical setting where you be assessing patients for other medical problems. And the same for specimen collection. That can really be done in any setting where you have the appropriate PPE to evaluate a patient. You would not require anything additional for specimen collection. And if you were able to submit specimens for other infectious disease testing, such as STIs or nasopharyngeal swabs for viruses, then you should have access to packaging and transport that meet the current requirements from Transport Canada. They just asked for an additional note on the outer side of the packaging called Category B. That is what's currently used for potentially infectious specimens, and it has a code on it saying TU 0886. I will admit there has been some issues with some of the couriers feeling comfortable transporting these specimens or assisting with the labeling, but I think that's being worked through, and hopefully soon enough there'll be a smooth process for getting specimens to the testing laboratory from any site. Just skip that slide. So in terms of the actual lab tests, as mentioned, monkeypox is in the orthopox virus genus, and it is the only orthopox virus currently circulating in Canada. When the outbreak began, many labs, including in Canada, provincial labs, have had an assay in place for the orthopox virus genus, and it was a part of a bioterrorism panel, and that was validated for testing environmental samples on the sort of bioterrorism front. And the CDC did quickly say that that assay can be used as long as it can be validated for clinical testing, because it will detect monkeypox as well. And they would classify someone as a probable monkeypox case if they had the appropriate clinical presentation and had a positive orthopox virus PCR. So in Canada, with guidance from the National Lab and the Canadian Public Health Lab Network, those labs that had access to that assay started using it, and that's what we did in Ontario. We validated with clinical specimens that had been run in parallel at the National Micro Lab, and that really helped us get the validation done very quickly. When we produced our lab reports, we did put a comment that monkeypox virus was the only member of that orthopox genus detected in Canada recently. So it was a staged validation. So we first were able to report out our negatives, because we had a large number of those. And then once we got to around 20 to 30 positives done in parallel with NML, we were able to put our positives as a final report. Up till then, we reported them as preliminary detected. And then once it became clear that this was one of the main assays endorsed by the World Health Organization, an assay developed by the CDC, I think it was published in either 2010 or 11, we quickly then also validated this assay and implemented it on June 23rd. This assay had, the original publication has 3 targets, one for monkeypox, a pan-monkeypox target, one for the West African clade, and then another one for the Central African clade. What we did was we actually multiplexed the monkeypox and West African into one well, and also added an extraction target for human RNase P all into the single well. And we basically report out each of the targets as they come, and we say that detection of either of the targets is sufficient for lab confirmation, given that they both are really independent monkeypox targets, and the West African one is more specific for the clade that's causing the current outbreak. And then we can have detected, not detected, or indeterminate results. Invalid is when the human extraction control fails. Here you see these are the cycle threshold ranges that we use. We're using up to 38 for detected, and then indeterminate 38.01 to 39.99. So we have found, given that there has been a lot of testing, I think there needs to be a balance between, as Adrian has pointed out, like not being too biased in that, like be open to testing patients when they have certain clinical presentations, but also I think we need to take into account the pretest probability. We definitely have had several patients, in particular in the pediatric age group or females, where if you look back at their history and presentation, you could reconsider whether they really needed to be tested for monkeypox. Even, you know, with excellent specificity, we are seeing occasional false positive results. There has also been, I think, just part of ramping up a new test quickly, there have been occasional false positives probably related to some contamination that's occurred. And it appears to be, in our lab, it's contamination of the primary specimen, so maybe related to the actual handling of the specimen within the laboratory. So that's resulted in us having to do, we're doing a lot of further investigation of samples when the epi doesn't match. So that would be adding things like enterovirus, HSV, rerunning with the orthopox assay and repeating the monkeypox testing. We are also actually routinely doing enterovirus PCR on all pediatric samples because that is by far the most common cause, I think, of whatever's causing a rash in children at the moment. So we actually just have modified our reports in the last, or actually today is the first day we're doing it more routinely. We're starting to actually like show that when it's indeterminate, you know, this is the cycle threshold value. For a low level, we're saying that in our comment, the cycle threshold was 35 or above. And that's important for when you know, there's only one sample positive, or we only received one sample. It's sort of a clue to the submitter that, you know, they really need to look closely at the epidemiology, and in particular the public health units will follow up to decide whether it is a true case or not. For females and children, we're actively going to be like, we reinvestigate any positive female or child. I'll just skip this slide, but for the other thing that's happening is that nationally, we're sending one positive specimen from each patient to the National Microbiology Lab for whole genome sequencing to help with monitoring the molecular epidemiology of the outbreak. Just pointing out, there's no individual report sent back, but there will be surveillance reports put out at intervals, I suspect. So I want to show you here, this is probably the slide I'll spend the longest on. We've just put together a quick write-up that we've just submitted for publication, looking at the tests for, it was about close to around just under 300, around 270 patients tested between May 22nd and June 26th. And amongst them, I think it's around 80 positive patients. So, you know, we really wanted to try and get some local data on the different test performance to see whether we needed to get multiple specimens and how many do you really need from each patient. So I'll just go through just quickly. So this is just looking at the different specimen types, the percent positivity. So of all blood, 15% were positive, of all nasal or NP, 15%, of all throat or oropharyngeal, 30% were positive. Skin lesions also 32%, and urine 15%. The next line is probably the very most helpful line to look at. So this line is amongst positive patients. So the denominator in all this row is patients that we know are positive, i.e., you know, one of their different specimen types was positive. And then we're looking at the positivity of each of these different types of specimens within that patient group. So amongst positive patients, blood was positive 43% of the time, nasal or NP 56%, throat or oropharyngeal 67%, skin lesions 83%, so much higher than the others, and urine 29%. We did get a lot of questions about whether throat or NP, like is throat potentially better than NP? This data suggests that maybe, but what we don't know is whether these people had throat specimens collected because they had oral lesions. So there you would expect it to have like a higher positivity rate. But I think it'd be interesting to see what other data comes out from other groups, but throat may be better than NP. If we look at the CT values, the cycle threshold values, the number of rounds of amplification that had to be done before getting the positive signal within the assay. So a lower CT value implies that the test is more sensitive indirectly, because it's sort of picking up, it's getting to that signal with less rounds of amplification. And so you can see that skin samples, this is from the orthopox, the pan-orthopox assay, and this is with the newer monkeypox assay. Skin had lower CT values for all these 3 targets by several cycles of amplification. You can see the monkeypox assay was also about 4 CTs lower than the orthopox assay. And then we did have like a small number of semen and saliva. These were, the semens were from known positive patients, and 2 out of 5 came back positive. Saliva, we just had 4 submitted, but 1 was from a monkeypox patient and was positive. This next analysis, we looked at all patients that had both NP and throat collected. So we're trying to look at the parallel performance. So all patients that had either NP or throat plus skin submitted. So we're trying to compare the skin and the NP or throat. So amongst 78 patients that had both of those sample types collected, at least 1 skin specimen was positive in 92%. So at the patient levels, the skin has a really good sensitivity. And I think on average, we got, I think, about 3 skin specimens per patient. Whereas the NP and throat was only detected in 56% of that same patient group. So amongst them, 49% of the group had both the NP or throat plus skin positive, whereas 44% only had the skin positive. There were 6 patients that did have a positive NP or throat, skin not detected. It's probably really 4 of them, because we did have amongst 2 of them swabs submitted. They just weren't labeled in terms of the site. And the other important thing about blood is we have not had a patient that was positive in blood, but was not positive in at least 1 other specimen type that came in, either mostly skin, but occasionally an NP. So there probably isn't a lot of utility or need to collect blood specimens on most patients. Probably the exception is the patient who's a known contact of a case, and they have that prodromal febrile illness and no skin lesions, or if the rash is only macular or papular, then it's probably reasonable to do the NP or throat plus the blood collection. And then in the pediatric population, it may be reasonable to also consider adding that NP swab in case we want to look for other respiratory viruses beyond enterovirus that could cause rash and fever, such as adenovirus. Of course, finding enterovirus in the actual lesions is way more definitive than just finding it in an NP swab, because it can be shed for many weeks after an infection. Whereas if you find it in the skin, then that's definitively, the cause of the current presentation. So with an individual skin specimen having a sensitivity of around 85%, we think that a maximum of 3 skin specimens is sufficient, and probably 2 is even enough. And if you're able to get that many, 2 to 3, there's no need to really collect the NP or the blood on most patients. Interestingly, the FDA just put out a notice a few days ago saying to really only submit lesion swabs for testing, and they advised against doing things like NP, blood, urine. It's a bit vague as to why they sent this message, but I think their warning is that you may get false positive and false negative, and it might just be out of abundance of caution because there isn't a lot of data out there on the test performance of the alternative sites. I think we've shown that you can test the other sites, but they're just not as sensitive. So I don't think we need to follow that in Canada, but I think it's helpful to know to put out this sort of comment warning. And then just getting towards the end of my slides, but wanted to point out that we did find enterovirus in 71% of the 35 kids that we've tested so far. And as I said, we're doing it universally on all children. And we do it on adults when requested or if we're investigating further. And it's not even uncommon in the adults. So of the 15 adults that we've tested, 47% were positive. But the adults, that would be a biased subgroup of the adults because it's the one where, you know, the diagnosis is doubted or we're investigating further due to initial possible false positive monkeypox results. So I think, and just speaking as a pediatrician that does clinics, and I'm seeing a lot of kids now with rashes that I think are enterovirus, and it doesn't just have to be the full hand, foot and mouth. Most of them don't really have that, to be honest. It's often a rash that, you know, might not, you know, that's just a technical description where you have to have the mouth, the hands, the feet involved. But, you know, kids with rash that looks like an enterovirus illness, my opinion is don't need to be swabbed. I think as Adrian pointed out with the case that they had presented, and there's a high risk that if you get a positive test for monkeypox in those patients, it's going to be a false positive and will require a lot of extra follow-up to get to that conclusion. And just a reminder, I suspect it is in most provinces, but can't speak for all of them, but at least in Ontario, you know, all suspected patients must be reported to the local public health unit. If anyone wants to look at what we have for resources in Ontario, that's some links to some of our resources. Just mentioning that we did initially require people to phone us if they were testing someone, but at this time we don't require that anymore. It's enough to like fill in the appropriate information on the requisition. Just a lot of people to thank, you know, really within our reference lab from top to bottom, just about everyone's been involved in our response to monkeypox, as happens with our emerging infectious diseases. A big thanks to the National Microbiology Lab and the Canadian Public Health Lab Network. As I said, it was the NML that helped us set up the testing that we have and are providing the National Reference Lab expertise. Thanking our provincial ministry, and I'm sure across the country, all the provincial ministries need to be thanked. And then just within Ontario, just with the data that we were able to show, thanking all of our network of microbiology labs within our province and our clinicians. And that's the end of my talk.
Perfect. Thank you, Dr. Bay, for the great presentation on lab testing. We'll now begin the question period in the Q&A tab, as well as some of the pre questions that we have submitted as well. Just a reminder, you can give any question a thumbs up, push it up in priority if you feel the need, and we'll try to get through as many questions as possible. I'm going to direct the first question to Dr. Chan, and it's really just about adding some potential comments or thoughts that you might have on the comments regarding de-roofing of lesions.
Yeah, so I think I would comment that as we're getting more experience with it, I think not all the lesions are amenable to de-roofing. And so some lesions that are very early on in the disease, there just might be enough juice or de-epithelialization that you can actually unroof the lesion, similar to how chickenpox or herpes sometimes looks early on. And so often what I'll do when I see, so if there's no vesicles, we'll just sometimes do a dry swab. And then if there's no lesions, and for example, someone has symptoms somewhere else, like pharyngeal symptoms or in particular rectal symptoms, we'll go after that because the yield on rectal swabs in symptomatic people actually seem to be really good. And it also seemed to be persistent in anecdotally in some patients in the cohort study, for example, that Dr. Tan has been involved in, where they're doing subsequent swabs. So I think that's a good place to go if there's no specific lesions to swab. The technique that I use, if I'm going to try to get a fluid out of a vesicle that's difficult to unroof, is I'll grab the swab slightly closer to the flocked end so that I have a bit of grip, because the actual swab itself is usually quite floppy and can break, just so I have a bit of traction. And then I'll just kind of twist my hand really quickly until I can get enough fluid out of there, or there's a little bit of unroofing when that occurs, that I could get a sample, and then that's what I send off. The one thing to note is, again, because it can be uncomfortable, is I really try to avoid areas where I think it might be painful.
Great. Thank you, Dr. Chan. I'm going to open this question up to Dr. Gabe and Dr. Chan if you have any comments. One of the questions that came in the Q&A was in regards to wastewater testing, whether or not it's been implemented yet for monkeypox surveillance, and where that might be occurring nationally.
Yeah, I know there's been some discussions about potentially doing it, but I'm not aware of anything actually occurring as yet. Yeah, I don't know whether there will be either, but I know it's been talked about, you know, with the COVID wastewater surveillance. I think now as every new virus emerges, there's a discussion. There was around doing adenovirus when there was the hepatitis in children of unknown etiology that emerged. And yeah, but I don't know exactly. I haven't heard of anything specific actually being set up yet.
I haven't heard of anything specifically from a public health perspective, but I do know that some research groups that have interest in wastewater surveillance, for example, Robert Delatola's group in Ottawa, have been looking into validating assays to potentially look at it, but I don't know how far along they are with that.
Great, thanks. And actually, the next question, I'll go right back to Dr. Chan on this one. And this again came from the Q&A, but it certainly is something that I've got an interest in as well. Is a question about the duration of viremia in the asymptomatic period, or during even that early prodromal period. Do we have any sense on what that looks like? Certainly, animal models, we're still waiting for you know, some first of all development, and I think you know, and results for certainly the current clade. But do you have any observations that you've seen or heard of?
I think Jonathan could probably comment to this as well. Like, part of the issue is for clinical samples, we're only doing them when we see patients, right? And there's obviously going to be a selection bias because we're much more likely to do blood on patients that feel like they're kind of in that early, you know, viral febrile phase essentially. And so that might slightly increase the yield of who we're getting at for when we're selecting for them. At the beginning, when we were just doing every sample at every site on everyone until we got a sense of it, the yield definitely didn't seem to be anywhere as good as doing the skin. And I know that Dr. Chan and a number of colleagues have tried to set up a cohort study to essentially look at that by doing serial sampling over time. The one thing, clearly it's going to happen early on though, and I don't think many studies have looked at that. I think that UK report where they looked at the 7 or 8 cases that they initially published in the Lancet ID earlier on prior to this outbreak had some data on that, but I think I haven't seen any other published data on human serial surveillance of viremia during the asymptomatic period.
Great, thanks. And Dr. Gabe, I don't know if you had any comments on that question.
Were you asking us about the viremia in general?
I mean, the viremia more so in the asymptomatic period or prior to the prodromal phase.
Yeah, no, I don't have any particular information on it. Just that the viremia does not seem to be very high level based on like what we're seeing in the lab, and that, you know, CDC has also put on their website that blood appears to be a low risk specimen in terms of lab transmission, because we're seeing very high CT values even when we're picking it up during the symptomatic period. But yeah, I'm not sure in the pre-symptomatic period how much there is.
Great, thank you. And another question, this is actually a bit of a two-part question. So this was from one of the pre-submitted questions that came in. So this was a question in regards to any sort of methods to try and increase the sensitivity of viral detection from lesions. I think that certainly you've already talked about certainly swabbing lesions. And historically, we know that there is, you know, we can get very high signal from those samples. But have you had any insights in regards to being able to increase sensitivity, or how you may be able to do that in a position where you need to?
I mean, I think the only variable that you can change is, I mean, the main one that obviously was used initially. You've heard about the idea of submitting dry swabs, so there's minimal dilution. But to be honest, it's probably not having that much impact if you just do the math. Like each CT, each cycle of amplification is like that doubles the amount of genetic material. If you half dilute like what the amount of volume it's in, that would be equivalent to adding one cycle of amplification required to detect virus. But I think the main thing is that like the CDC talk about doing maybe double swabbing when there's only one lesion, and just the law of like doing percentages. If you collect multiple swabs at the patient level, you saw our data showed that your sensitivity went up to 92% when you looked at all the specimens that are skin specimens that someone had come in versus 85 if it's one. So I think that's really the main thing. But within the lab, there isn't anything that we've like been able to do on top of that.
Great, thanks. Dr. Chan, this, I think, again, another question that certainly has me quite interested as well. You know, when we think about this idea of monkeypox, classically, we think about, you know, the synchronous lesion development and then resolution. And certainly in this global outbreak, we've heard much more about the asynchronous lesion developments and certainly like some discussion about how resolution has looked. Have you had any insights in regards to the time range for resolution of different types of pustules or ulcers, in particular, looking at different regions of the body where those may be occurring?
I would say that it seems to be variable, if that makes sense. Some people seem to have a more rapid progression than others, where they go through the whole cycle in like a week. And then there are some people who like it feels like it's needing to take, you know, almost the whole like 3 to 4 weeks before things settle completely. The occasional person will have a couple new crops, in particular if they maybe have some predisposition to immunocompromise in some way. The one thing I have noticed is that the non-skin lesions seem to persist symptomatically slightly longer. So in particular, the perirectal disease, people will have, they'll feel their skin lesions completely dry up, but there seems to be some persistence in some of the mucosal areas that lasts a bit longer. And I understand from anecdotal report from one of my colleagues downtown who saw an esophageal lesion that happened later on in the course. So yeah, we're still learning, right? And so I think probably more to report back on as we see more case series and other data cohort information coming out.
Great, thanks. And actually, I've got a second part to that question that I think is something that we've been discussing quite a bit. Have you seen any link in those cases where you see faster resolution? Any kind of I guess linkage to prior vaccination? I mean, certainly the age groups don't necessarily fit, but in those that maybe had it for work reasonings or otherwise.
So I mean, we definitely, it's hard to say. We've had a few older patients who would have had the like old school smallpox vaccine or smallpox original vaccine, right? And I wouldn't say that their course was any different than what we've seen. Data on vaccine effectiveness in the context of like I think in Toronto and Quebec, maybe not so much in other places, there has been a reasonably aggressive pre-exposure prophylaxis strategy for vaccination. In particular, trying to get as many people who potentially could have some risk as possible prior to Pride events happening. And we are seeing monkeypox obviously in people who've had the vaccine, likely because there was exposure within the period where they were still developing immunity. And so yeah, I can't really say beyond, obviously there's going to be like bad cognitive attribution to things, so I don't want to really comment on it. But I know Jeff Kwong and a number of other colleagues are looking at this, and so it would be again interesting to kind of see if time to resolution of disease or if there's an impact related to having received the vaccine recently.
Perfect. Thank you for that. One of the other questions that has come in is certainly, I think, in probably well into everybody's mind, given what we're dealing with COVID. And I'll ask Dr. Dubé to answer this. in regards to reported cases in children where the contact with positive cases was not necessarily direct?
Definitely from the current outbreak, I mean, we've heard 2 reports in Europe of pediatric cases. One was contracted from the father. The other, I think they'd recently traveled to another country, Turkey, but there was no, they couldn't establish the epi link for the child. So no, and I'm definitely in Ontario, we haven't had any pediatric cases, and I don't think in Canada. Apart from one adolescent case, but yes, I'm not aware of that happening in children as yet.
Great, thank you for that. One of the other questions that was pre-submitted, which I think is itself quite important, again, coming through what we just did with COVID. I guess for you, Dr. Chan first, and Dr. Gabay, if you have any thoughts, what are your recommendations for isolation for low-risk patients that are awaiting testing?
There's guidelines that have been released by PHAC around appropriate isolation. It is in my, I think I put it in my slides, so they will be available. And I think Dr. Longtan also spoke about it. But each individual public health jurisdiction will also have recommendations on what to do for isolation. Now, I've looked at a few. Obviously, I am, beholden to the Toronto Public Health ones. I actually quite like the UK HSA ones, just for interest, and I can try to pop that up. But they have a very, very detailed rundown in their UK guidelines for what to do for home isolation if you're waiting for testing and are a probable case. Now they've stopped asking contacts of cases to isolate. I think just because the impact, I think, on livelihoods, etc., compared to the risk doesn't make any sense, and especially because of the need for really close contact. But I understand public health jurisdictions are kind of looking at this because of the long period of time that once people become positive, that they do need to remain in isolation. Really, the one thing I would say, there is no comparison to COVID, right? And I want people to remember that. Like, the good news is that it's actually not that transmissible. And so we have to keep that in mind. And it really is that close contact where skin to skin, mucosal membrane to mucosal membrane, where we're seeing transmission. And so as such, I think our recommendations are that if people can keep their lesions covered up and a mask on during their infectious period, in general, the risk of transmission, like in general contact, is going to be negligible, right? So I think that's one really important piece to remember. I think we all have a bit of PTSD from COVID, but it is not the same thing. So.
Great. Thanks for that, Dr. Chan. I certainly have my own thoughts and comments on that as well, and am in full agreement with you as well. One of the questions for Dr. Gabay on, and I think this has been something that again we've battled with many different viruses in regards to the quick access to molecular data, but not necessarily the quick access to infectious data. Is there any data that has been able to correlate infectivity through viral culture assessment with lesion testing through nucleic acid testing?
I haven't seen any data yet in terms of, I guess you're wondering about like what was done with COVID, where people would take samples and then see, does it grow at certain stages? I know our national lab was going to do some of that work, but we haven't received any information as yet, unfortunately. I think it can be a long process, the culture, like it can be weeks to decide. So I don't think they've managed to do enough and put any data together yet.
Yeah, and I think that's something that certainly we've had many discussions about with international partners. We need to know, but this also is an infrastructure question because of the requirement for high containment as well for working with infectious monkeypox virus samples. I'm going to go back to one of the questions that's come up in the Q&A, and I think this also is quite interesting. I'll go to Dr. Chan first. So we know that monkeypox virus has a fairly wide tissue tropism, and certainly I think we're seeing some of that right now. Have you had any observations for uncommon or severe sequelae after viral clearance?
Like a post-infectious kind of syndrome?
Yeah, I can only go based off what I'm seeing in the question, but I would assume that this is yeah, basically any kind of longer term or even shorter term post post viral clearance, post lesion resolution types of sequelae that are showing up in patients.
So probably the most common thing is again kind of residual rectal symptoms that we're still trying to figure out right now. We have a couple patients who are still complaining of just general discomfort. These are patients who also had received tecovirimat, so had rapid resolution of really quite remarkably rapid resolution of lesions and symptoms on that still feel a bit of discomfort. And so I don't have the answer on that because I'm waiting for the anoscopy to be done. But I'm sure we'll be learning some. And again, just the description of this kind of scar or lesion that looked almost like a possible NSAID induced in the esophagus. It ended up being PCR positive. In terms of like long-term sequelae like we see in other viral infections, I think one can assume that something will happen. We've seen it with Ebola, we've seen it with mono, we've seen it with COVID, but I don't think we have a good sense of characterization of exactly what that means. Yeah.
Perfect, thank you. And I'll go back to Dr. Goubet on this question, and I would suggest there's probably not an answer at this point, but do you have any thoughts on the potential for spillover of monkeypox virus to national, animals in our national population? Do you have any thoughts on that?
I think there has been some discussion on that. I think that the natural host is thought to be within rodent populations, so there definitely is the potential risk, and I know our animal health partners are sort of thinking about that and talking about that. So there is the general advice that if possible to avoid direct contact with animals when sick with monkeypox. It's definitely a possibility and something that will need to be monitored.
Great, thank you. I'm going to go back to Dr. Chan on this question. When do secondary lesions typically start, from what you've seen through other literature and your own direct observations?
Well, usually you'll have the primary site of inoculation, and then maybe like day 3 to 5. You might have a prodrome, and then the secondary crop of lesions happen at that time. So I would definitely within the first few days. Yeah.
Perfect, thank you. And I'll go back to Dr. Goubet with this question. It was a question in regard to cleaning of lesions and potential interference with any of the diagnostic assays. Are there any considerations that you think are important for people to keep in mind?
I don't believe that, like, say, the direction is to maybe you might clean with an alcohol wipe before de-roofing a lesion. I mean, that shouldn't interfere with the diagnostics. Just like we've been doing molecular testing for years on lesions being sampled after skin cleaning, the alcohol shouldn't interfere with molecular testing.
Great, thank you. Dr. Chan, for back to you for a question. So one of the questions that's come up in the Q&A was about any correlations or potential correlations between the rates of adenovirus in children and positive secondary infections in the cases of infant hepatitis of unknown origin. Do you have any thoughts on this at all?
Off the top of my head, no. Yes, I think it's not monkeypox related, right? Yes. Okay. So I don't have a comment on that. I think the information is out there. I think everyone's certainly looking at what the potential etiologies are, but I don't think I have anything to add beyond what the other experts have already said.
Great. Thank you. One of the questions that's come up, and I'll pose it back to either of you, is a question in regards to sources of transmission. There was a question about hot tubs and the potential for potential transmission of monkeypox virus in the absence of intimate contact. Do either of you have any thoughts on that type of situation or a similar situation in regards to contact and what we currently know about, particularly this clade of monkeypox virus?
I don't have too much to say on that. I mean, I'm wondering whether the temperature of the water and disinfect whatever the like chlorine may inactivate virus, and it'd be more the fact that people are just getting together, like being close, would be the risk factor within a hot tub.
Like in the cases that I've seen, there usually is sexual contact that I think, based on the site of inoculation, I think would be the most likely. My sense is that the risk is more related to that than anything else. Obviously, Alison McGeer and a number of people, including Jonathan, are involved in environmental studies. And I think the UK group, the big group that kind of published their high consequence pathogen group, has been doing tons of sampling of environmental areas. And so hopefully we'll get more information around that. Like, certainly we know that the DNA can exist on surfaces before it's cleaned. But whether or not there's culturable virus, I don't think there's a ton of information about that right now, just as labs are kind of getting up running to look at that. But I think we'll have more information soon.
Yeah, I appreciate that. And certainly I think one of the things that we can always reflect back on is, listen, monkeypox is certainly fairly new to many global regions right now, but we have to appreciate that there's 50 plus years of historical, epidemiological, and clinical data from endemic regions that certainly help us or help inform what we understand about transmission for this particular virus. So there are questions that are unanswered, but we still have a lot of answers too from what we've seen historically. And I think I'll wrap it up with one last question. And this will go back, I think, to mostly to Dr. Gabbay. So if somebody has tested a lesion, they've taken a swab, what are the next steps in the process? What should they do with that particular test sample, and certainly in regards to submission?
I mean, depending on your jurisdiction, like I said, in terms of like the way you package it, it's very similar or the same as if you're used to preparing other clinical specimens that are potentially infectious for submission. So, in the appropriate, putting in the appropriate biohazard bag, and then it being packaged like in the photo I'd shown, like meeting those category B requirements, which are no different to before, and having it appropriately labeled on the outside. And if you're in at a particular community location and you have a regular courier, it's probably a good idea to just check in with them to make sure that we're all on board, that they will be transporting your specimens. And if you get any pushback, then you may want to raise it with your local public health authorities and your ministry, just to see what are the roadblocks to getting the specimens to the testing lab, and to make sure to use the correct requisition. So in Ontario, we want you to use, say, our public health lab rec, not the regular ministry rec for other testing. So just to check all those things out in your jurisdiction. So that would be the key things.
Perfect, thank you. Listen, I just want to go through the wrap up now. Certainly to extend a big thank you again to both Dr. Chan and Dr. Gabbay for their presentations today, and as well to all of you who were able to join for the webinar. The recording again from today's webinar will be available shortly on the NCCID website under the webcast tab. Also, please fill out the short evaluation, which you'll receive shortly if you don't mind. And from me and certainly from all of the rest of us here, thank you again to everyone, and enjoy your day. Thank you.
Thank you.